Let's continue talking about our cardiovascular physiology. What we are looking at right here is an ECG tracing. ECG stands for electrocardiogram. An ECG is basically recording the electrical activity of your heart. An ECG represents a summation of multiple action potentials taking place in your muscle cells. And because it's a summation of a bunch of action potentials, when you look at the ECG waves, they are not going to look like a single action potential taking place in your heart. When we look at this tracing right here, this is representing a sinus rhythm, meaning that everything is absolutely normal. So if everything is normal, this is how the waves should look like. Now, one thing to note before we explain what those waves represent is that a mechanical event is always going to follow an electrical event. So following a depolarization wave, you are going to have a contraction. Following a repolarization wave, you are going to have relaxation. This right here is our P wave. Then we have three waves right here, Q, R, and S. Collectively, we call it the QRS complex. And then we get the T wave right there. There are segments, and the segments are basically areas in between the waves. We've also got intervals. The intervals are a segment and a wave. So right here, the PR interval is this whole entire area, including the P wave and the PR segment. Then we get the QT interval, which is basically the T wave, the ST segment, and the QRS complex. The P wave is representing the depolarization of our atria chambers. As I said, following depolarization, we get contraction. So right after the start of our P wave, the atria will start contracting, and they will contract up to the PR segment. The QRS, or actually before talking about the QRS, this PR segment right here is actually representing the electrical or the action potential moving from the AV node down to the AV bundle. So that's the PR segment right there. The QRS wave is representing the ventricular depolarization. And one more time, following depolarization, you would have contraction. So right after the start of the Q wave, the ventricles will actually start to contract. Now, if your atria have already depolarized and they've already also contracted right here, the atria needs to repolarize and relax. So when is that going to happen? That happens right here. During the QRS, your atria are going to be repolarizing, and then following that, they will be relaxing. The T wave is representing the ventricular repolarization, and following its start of the T wave right away, your ventricles are going to start to relax. So if we are going to trace the ECG waves together, we are going to start right here with our SA node, since we said it's the one taking lead. So you can see right here the SA node in your right atrium. The SA node is going to go ahead and initiate the action potential. The action potential, you can see right here, the purple waves. You can see that the depolarization wave of the action potential is spreading throughout the atria chambers, and you can see that the P wave is starting to form because the atria are depolarizing. And you can see that right here, they are still depolarizing, and the message is spreading throughout the atria. And you can see that the action potential is starting to move to the AV bundle and the branches, and we are already like right here at the PR segment. Now, following the start of the P wave, your atria are going to contract. As the message moves from your AV node to the AV bundle, as we said, there's going to be a bit of delay. So there's going to be a bit of delay at the AV node before it reaches the AV bundle. And the reason why we have that AV node delay is because we want to give time for your atria chambers to contract and push the blood into the ventricles. Following that delay, you're going to see that the electrical message is going to start moving down the AV bundle and into the Purkinje fibers. And you can see right here, we are starting to see the QRS wave on our ECG diagram. Now, following the depolarization of our ventricles, we are going to have contraction. So your ventricles are going to start to contract. Now, after your ventricles contract, your ventricles will have to relax. So your ventricles first, before relaxing, they have to go through repolarization first. And so you're going to see the T wave right here. Following repolarization, your ventricles are going to relax. Now, when is your atria depolarizing and contracting? As we said right here, during the P wave. Following depolarization and contraction of your atria must repolarize and relax. And so when is that going to happen? That's going to happen during the ventricular depolarization. So as you're getting that QRS wave on the ECG diagram, this is when the atria are repolarizing and relaxing. So this right here is the electrical events taking place during our cardiac cycle, and this is explains to you kind of how we are getting those waves on our ECG. A quick anatomy refresher. When you look at the heart, we have the atria chambers up here. We've got the ventricle chambers down here. The right side right here is dealing with deoxygenated blood. The left side is dealing with oxygenated blood. The right atrium is going to receive blood coming from your vena cavas. The blood flows from high pressure to low pressure. So once the pressure in your right atrium increases, the tricuspid valve is going to open up. The tricuspid valve, you can refer to it as an atrioventricular valve since it's between an atrium and a ventricle. That tricuspid valve opens and the blood is going to start rushing into the ventricle. Now, once the pressure in the ventricle increases, the ventricle starts to contract, but that contraction is not going to be strong enough to push the blood out of the ventricle. That initial contraction is going to close up the atrioventricular valve to prevent basically any backflow into the right atrium. But as the pressure in the ventricle increases and it's contracting, it's starting to contract even more. Of course, the AV valve stays closed, but another valve is going to go ahead and open, and that's the pulmonary semilunar valve, and the blood is going to be pushed out of the right ventricle into the pulmonary arteries, where the blood is going to go to your lungs to pick up oxygen. After the blood gets oxygenated, it's going to make its way into the pulmonary veins, where it's going to drain into the left atrium. the pressure in your left atrium is going to start to increase, forcing open another atrioventricular valve known as the bicuspid valve, and the blood gets pushed into the left ventricle. The pressure in the left ventricle starts to increase, forcing the bicuspid valve to close to prevent any backflow into the left atrium. The left ventricle starts to contract more and more, and that's when the blood is going to be passed into the aorta, and there's another valve right here that will open up, known as the aortic semilunar valve. It will open, pushing the blood into the aorta. Once the pressure in the aorta increases, and now the pressure in the aorta is higher than the pressure in the left ventricle, the aortic semilunar valve is going to close, preventing any backflow into the left ventricle. And then the aorta is going to send the blood into all of the body tissues. One thing to note as well is that once the pressure in your pulmonary trunk right here and in the pulmonary arteries is higher than the pressure in the right ventricle, that pulmonary semilunar valve is going to close, preventing any backflow into the right ventricle. Now, when you listen to your heart and you hear lub dub, that first sound, that lub sound that you are listening to, or we call it S1, the S1 is due to the closure of your atrioventricular valves, which is basically your bicuspid right here and your tricuspid. So when your tricuspid and bicuspid valves shut close, that's when you hear S1. That's when you hear the lub. Now, following lub, you get that other sound, the dub sound, and that's when your semilunar valves are shutting closed. That's when your pulmonary semilunar valve and your aortic semilunar valves are shutting closed to prevent any backflow into your ventricles. And so when those semilunar valves close, that's when you hear the S2, the second heart sound. Let's look at the events of the cardiac cycle right here together. Right here during this stage, all of your heart chambers, they are actually in a relaxed mode, or we call it diastole. That's because you can see the atria, they are filling up with blood, and the ventricles are passively getting filled with blood without the atria chambers contracting. And so right now, all of the chambers of our heart, they are actually, as I said, relaxed. Now, the blood flows from high pressure areas to low pressure areas. So as the atria gets filled up with blood, both the right atrium and the left atrium, they're going to be filled up with blood at the same time. The pressure in your atria is going to start to increase. As the pressure in your atria increases, those valves right here, the atrioventricular valves, we've got the tricuspid valve and we've got the bicuspid valve, they're going to open, allowing the blood to flow from your atria into your ventricles. Now, so far, the atria did not contract yet. The atria is going to be able to push the blood into the ventricles without any contraction. But when there is the last bit of blood in your atria, about 20%, that's when your atria are going to contract to push that last bit of blood into the ventricles. And when that happens, we say that your atria are now in systole, meaning your atria are now contracting to push the blood into your ventricles. And as we said, Mechanical events follow electrical events. So the atrial systole is going to start right after the beginning of the P wave. So the atria has to depolarize first, and then following the atrial depolarization, you are going to have the atrial contraction. And in the meantime, as the atria are actually contracting to push that last bit of blood inside of them into the ventricles, what's happening electrical wise is that the electrical message is moving from the AV node down the AV bundle. And as we said, we're going to have a bit of delay when the message moves to your AV node before it goes to the AV bundle, because as you can see, we want to give time for your atria to contract to push that last amount of blood into the ventricles. Now, what happens is as the blood is rushing into the ventricles, the pressure in the ventricles keep rising. When the pressure in the ventricles exceed the pressure in your atria chambers, the atrioventricular valves must close. And so the reason why the atrioventricular valves close is because you don't want any backflow of the blood into the atria. And so that's why the atrioventricular valves must close. Now, when those valves close right here, that's when you hear the first heart sound, the first heart sound, which we refer to it as S1. That's the lub that you hear. Now, right here, as you can see, the atrioventricular valves have closed, as we said, but the semilunar valves have not opened yet. And so right here during this stage, you can see that all the valves are closed. And so whatever blood is in your ventricle during that stage, it's not going anywhere because the valves are all closed. And so we refer to that stage as isovolumic ventricular contraction. Iso meaning the same. So the amount of blood right now in your ventricles stays the same since the valves are closed. And your ventricles, they are about to contract right now. And so that's why they call it isovolumic ventricular contraction. Actually, the atrioventricular valves, as I said, they closed because the pressure in your ventricles exceeded the pressure in your atria. And actually, the ventricles can do a very tiny amount of contraction. We call it the first phase of contraction. And that just closes the atrioventricular valves. But it's not a strong contraction to open the semilunar valves or to push the blood out yet. Now, since this blood right here in this isovolumic contraction state is not going anywhere, and it's the maximum amount of blood that the ventricles would receive, because again, all the valves are closed, we refer to that as the end diastolic volume. So the volume in your ventricles right here is known as the end diastolic volume. Diastolic because, again, the ventricles have not really started their full strong contractions yet, and so we call it the EDV volume. Now, right here, you can see the pressure in your ventricles start to increase, and your ventricles are starting to contract so that they can push the blood out of their chambers. That's when the semilunar valves go ahead and open. And so when the semilunar valves open, that's because the pressure in your ventricles is now way higher than the pressure in the aorta and in the pulmonary artery. The ventricles are going to contract, and the semilunar valves, of course, got to open so that the blood can rush into those arteries right there. Now, of course, the atrioventricular valves are still staying closed. Once the pressure in your artery your aorta artery and your pulmonary artery exceeds the pressure in your ventricles, the semilunar valves will close to prevent any blood from going backwards. If we connect to what's happening here with the whole ejection of the blood out of the ventricles with the electrical activity, as we said, the ventricles have to go through a depolarization wave first, and then following that depolarization wave, we are going to have the contraction of our ventricles. And during all of this, as the ventricles are depolarizing and as they are contracting, the atria are actually repolarizing and relaxing. When are the semilunar valves going to close? As I said, the semilunar valves are going to close when the pressure in your aorta and in your pulmonary artery exceeds the pressure in your ventricles. They must close to prevent any blood from going backwards. Now, one thing to note actually is that when the ventricles contract and push the blood out, the ventricles never push all of the blood out of their chambers. And so you're going to have a bit of blood left in your ventricles. And this blood is not going to go anywhere because the semilunar valves have already closed and your atrioventricular valves are still closed. And so we refer to that blood that's going to be left in your ventricles the end systolic volume. Why end systolic volume? Because your ventricles have already contracted, so they've already went through systole, which is contraction, and that blood is still left over, so that's why we call it the end systolic volume. And we refer to that stage as the isovolumic ventricular relaxation, because one more time, this amount of blood is not now going anywhere, and so the amount of blood in your ventricles right here stays the same. And so that's why we call it isovolumic, and your ventricles are in a relaxation mode right now, so isovolumic relaxation stage. And the cycle keeps going and it keeps repeating. So once the pressure in your atria increases and it exceeds the pressure in your ventricles, we're going to repeat the process one more time. The atrioventricular valves open, blood starts flowing into the ventricles, and the cycle keeps going. Right here, you notice that this is the stage where the atria is going through systole, so the atria are contracting. Then we can see right here, the ventricles are the ones contracting down here in that stage down there. And then of course, your atria are going to be relaxing right here, so they are in diastole, and you can see that there will come this stage right here where it says start. This is where actually all the chambers are in diastole, meaning relaxed, both your ventricles and your atria chambers. S1, as we said, to recap, we are going to hear S1 when your atrioventricular valves shut close, which is your bicuspid and tricuspid valve. When are we going to hear S2? We hear S2 when your semilunar valves close. Your aortic semilunar valve and your pulmonary semilunar valve. When they shut close, that's when we hear S2. If we look at this graph right here, we see that on the y-axis there is the left ventricular volume, and on the y-axis we have the ventricular pressure. And one more time, we are specifically looking at the left ventricle. If we start right here at point A, as the atrial blood flows into the ventricle, you notice that the volume in the ventricle is increasing. Right here, you see that we are starting off at 65 and the volume is definitely increasing in the ventricle because it's receiving that blood from the atria. Then we can see that the pressure in the ventricle is also starting to rise slowly. And right here, as the atria starts to contract, it's going to push more blood into the ventricle. Now, the ventricle right here at this moment is containing the maximum amount of blood that it can hold during a cardiac cycle. And the ventricle right here, it's still in diastole. It haven't fully contracted yet. And during that stage, all the valves are closed. So both the atrioventricular valves and the semilunar valves are closed. And so we call the volume right here in the ventricle the end diastolic volume. It's around 135 mils, but that volume can actually change if your heart rate is very, very high. If your heart rate is very high, meaning that your heart is contracting extremely fast, then your ventricles are not going to have enough time to get filled completely with blood, and so that EDV volume is definitely going to be lower if your heart rate is very high. Right here showing you from point B to point C, you can see that pressure-wise it's increasing, but volume-wise it's not. So this is representing the isovolumic ventricular contractions. The ventricles are contracting, but the semilunar valves have not opened yet, so that blood is not going anywhere, and so that's why the volume does not change. As you can see, the volume is not changing. Once the pressure in your ventricle increases the pressure in your artery, and in this case, the aorta, since we are concerned about the left side, that's when the aortic semilunar valve is going to open, and you can see that the blood starts to rush from the ventricle into the aorta. And you can see that there's a drop in the volume right here. So definitely right here, the volume, as you can see, was pretty high. And now we've got a drop in the volume because that blood is now has been pushed into the aorta. But as we said, the left ventricle is not going to push all the blood out of its chamber. So whatever blood is going to be left over in your ventricle, we are going to refer to it as the end systolic volume, which is the minimum amount of volume of blood in your ventricles during a cycle after the ventricle has went through systole. Now, the end systolic volume, it's around 65 mils. If you notice, 65 is about half of the 135. So actually, about half of the blood is going to be left over in the ventricle. Now, as the ventricles start to relax, you can see that the pressure is going to start to drop. So you can see right here from point D to point A, the pressure is dropping because the ventricles are starting to relax, and the cycle keeps going. If the end diastolic volume is the maximum amount of blood we have in our ventricle before it contracts, and the end systolic volume is the minimum amount of blood in our ventricle after a contraction. Can we figure out how much have the ventricle, how much blood did your ventricle really push out? Yes, subtract the two. So EDV minus your ESV is going to tell you how much blood is your ventricle really pushing. And that's known as the stroke volume. So the stroke volume is the amount of blood pumped by your ventricle during a contraction or with each beat. So you are right here. If your EDV is 135 and your ESV is 65 mils, then that means that with every ventricle contraction, your ventricle is pushing 70 mils of blood per beat. Now, your cardiac output is the volume of blood that's pumped by each ventricle per minute. And so to calculate that, we can actually multiply our heart rate, which is how many beats per minute we are conducting, and multiply that by your stroke volume, which is how much blood we are pumping per beat, not per minute, per beat. And so if you multiply the heart rate by the stroke volume, you get your cardiac output, and your cardiac output unit-wise, it's how much blood we are pumping per minute. So you're going to either say liters per minute or milliliters per minute. Basically, it's a volume per time unit-wise. Now, our parasympathetic nervous system and our sympathetic nervous system, they can actually change our heart rate. They can affect our heart rate, either increasing our heart rate or decreasing our heart rate. Our parasympathetic neurons, they release a neurotransmitter known as acetylcholine. Acetylcholine slows down our heart rate. Acetylcholine activates receptors known as muscarinic cholinergic receptors, and those receptors they are going to influence the flow of potassium and calcium. And so acetylcholine is actually going to affect the action potentials taking place in your autorhythmic cells. So remember, this was the action potential that we've talked about in your autorhythmic cells. Just a quick refresher, we said that we first have to open sodium channels and calcium channels so we can reach a threshold. Once a threshold is reached, then we can go ahead and start our action potential. And eventually we are going to go through repolarization as the potassium rushes out of the cell. So this is the action potential taking place in your pacemaker cells. And so acetylcholine can actually affect the action potential taking place in your pacemaker cells. How does it do that? It's going to, as I said, bind to certain receptors on your autorhythmic cells, and it's going to increase the potassium permeability. So that means it's going to increase the amount of potassium leaving your cell, and it's going to decrease the calcium influx. So basically, it's decreasing how much calcium is entering into the cell. So let's think about it. If you have a whole lot of potassium leaving the cell, that's going to increase hyperpolarization. So your cell is not going to start off, the resting membrane potential or your pacemaker potential is not going to start off at negative 60 millivolts. It's actually going to start lower. Do you see that blue graph right here? It's starting lower than negative 60. And the reason why it's starting lower and it's now becoming more negative That's because acetylcholine increased the rush of potassium out of your cell, making your cell more and more negative. Why is that? How is that going to affect the action potential? Well, if you are starting at a more negative value, and your calcium permeability is also being affected, your calcium permeability is decreasing, it's actually going to take more time for the cell to depolarize and reach a threshold, and therefore delaying the onset of the action potential and therefore slowing down your heart rate. So you can see right here with the blue graph, it's taking longer for the cell to reach threshold because you are decreasing the amount of calcium entering into the cell and you are increasing the amount of potassium exiting the cell. Your sympathetic neurons are actually going to do the opposite. They are going to increase the rate of the action potentials taking place in your autorhythmic cell and therefore increase your heart rate. Your sympathetic neurons release norepinephrine, which is going to act on the beta receptors on your autorhythmic cells. And what it does is it's going to increase the sodium influx. So you're going to have more sodium rushing into the cell, and it's going to also increase the amount of calcium also rushing into your cell. And so if this gray graph is showing you a normal action potential taking place in your autorhythmic cell, notice how the red graph, we are starting at a much less negative pacemaker potential or resting membrane potential. And the reason why we are starting off at a less negative membrane potential right here, it's because we've increased the amount of sodium and calcium entering into the cell. And so how is that going to affect the action potential? You're going to be able to reach threshold much, much faster because you are already starting at a less negative resting membrane potential. And so by increasing, of course, the action potential, you are going to increase the heart rate.